My name is Brendan Goodger. I'm the General Manager of Primary Care Improvement here at Central and Eastern Sydney PHN. Also with us from CESPHN is Christina Pargenta from our CPD team, who's going to be assisting with the webinar and making sure that technology all works. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay respect to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. So I can now introduce our first speaker for the night, Professor Lynne Madden, who's Professor of Population and Planetary Health at the School of Medicine, Sydney, the University of Notre, Australia. Professor Madden will speak on climate change and health and primary care. Now, a little word about Lynne Madden, Prof Madden. She's the inaugural Professor of Population and Planetary Health at the School of Medicine, Sydney. She has published extensively on public health, workforce and competency-based education, and there's more, and over the past 10 years on the contribution of the health professions education to adaptation and mitigation efforts to address the health effects of climate change. She chairs the Climate Change and Health Working Group on the Medical Deans of Australia and New Zealand and was awarded the 2019 Bond University Sustainability of Healthcare Award, Education, for this work in climate change and health in medical curricula in Australasia. This was further recognised by the Educators Innovative Universities Awards in 2020. She's a member of the RACP Climate Change and Health Reference Group, and she's also a trustee for the Lizard Island Reef Research Foundation of the Australian Museum, which supports research into the Great Barrier Reef and marine ecosystems. So Professor Madden is going to be giving us a talk on climate change and health in primary care. And there'll be an opportunity to ask questions as well. So, Prof Madden, over to you. All right.
Thank you very much indeed, Brendan. I'll just share my screen. Okay. Well, thank you very much indeed, Brendan. Thank you very much indeed for the generous introduction. And I'm honoured to be here. It's wonderful. And thank you very much for the invitation. So I would also just like to acknowledge the Gadigal people of the Eora Nation, which is the land on which I speak to you from this evening. So environmental sustainability, building a healthy future, and the role of primary care is my topic for this evening. And what we'll cover is what are the health effects of climate change? How do we know that these changes are happening? Where do we get our data? Some recent and encouraging developments, and how primary healthcare can make a real difference. But first, the IPCC is the world's most authoritative scientific body on climate change and reports every 8 years. These are the covers of the most recent set of reports. The UN Secretary General has provided pithy labels for these reports, which are overlaid here. The final instalment of the 6th report was released in March this year and confirms, and I quote, that human-induced global warming, currently at 1.15 degrees C, has spurred changes in the Earth's climate that are unprecedented in recent human history. That climate impacts on people and ecosystems are more widespread and severe than expected, and future risks will escalate rapidly with every fraction of a degree of warming. So what does this mean for Australia? Well, firstly, there is immense geographic variation around global warming, and Australia has actually already reached 1.5 degrees C's of warming. And the polar regions have actually reached 5 degrees warming. So for Australia, this means increasing intensity of heat waves, of fire weather, of heavy rain, and sea levels are rising here than the global average. the health consequences of this are increasingly apparent. I've popped this graph here, which is a slide of global annual temperatures, to remind me to mention that the World Meteorological Organization, which reported last week, has forecasted that the next 5 years will be particularly hot, and these are expected to be the warmest yet. There's an El Niño weather pattern coming through, and there will be individual years in the next 5 years that exceed all previous high levels of temperature. So how do we think about this in the context of health? And there's many models out there that sort of help you to sort of bring together climate change and health impacts. But this is one that I like. It's by Ebby and Haynes, and was published in the New England Journal of Medicine in 2019. And I've broken this into two parts rather than trying to talk to you about this one large complex diagram. Sorry, I'm missing. Sorry, okay, so some of my slides have disappeared in the transfer across. So I will actually talk to you about this in one large piece. So the just looking at the top half of this, that the exposure, so the exposure pathways that climate change affects people are through usually extreme weather events, heat stress, air quality, water quality, food supply and safety, vector distribution and ecology, and also social factors. And that how these impact on people are actually moderated through the demographic and social, environmental and other factors that moderate these effects. So for example, the sort of baseline quality of the local environment, the nutritional status and the health of the local population, the access to effective healthcare, these all moderate how those exposure pathways play out. And then looking down to the second set, and I will just simply flick to the next slide, which was what I was planning to do between the two slides, which was, recently in Sydney, we've actually seen these major natural disasters. And so we've actually seen we've seen these exposure pathways play out in our local population. So this going back to this and looking along the examples of health outcomes, we've certainly seen from extreme weather events, we've seen injuries and fatalities and the substantial mental health effects of extreme weather events. For heat stress, we see every summer the heat-related illness and death. Air quality will, we all remember the 6 months of fire smoke that came through the bushfires. We have water quality coming through the floods out around Hawkesbury, Nepean area. There were increased presentations of Campylobacter presentations. Food supply and safety, I'll just simply remind you of how much a lettuce costs for some of those months. Vector distribution and ecology, dengue is expanding its footprint. We've recently seen Japanese encephalitis extend from the Cape down as far as Melbourne for the first time. And then the physical and mental effects of violent conflict and forced migration, where we have all across Northern Australia into the Torres Strait, the rising of the sea levels, really making the Torres Strait Islands, once an agrarian society and a fishing society, many of those islands, they can no longer they can no longer have their own gardens for raising vegetables. I'm just wondering what my slides are going to do, if they've managed to eat two so far. So this is, so how do we know all these things are going on? How do we know that these changes are happening? Where do we, and where do you, where do we as a medical community get our information and data from? Well, where I get mine from, and where I go to first, is the Lancet and the Lancet Countdown series. And these are, excuse me, it's one of those nights for technology, isn't it? And also with the Lancet Countdown, which is so the Lancet Countdown's been produced annually since 2018, and it reports on 43 indicators of climate change and health, and it will do so annually until 2030. And the report is released in October or November each year, and it's released just prior to the Conference of the Parties. And so that it ensures that there's an up-to-date health report that's being fed into the national and international climate negotiations. So these are just the front pages of the Lancet Countdown over recent years. So this is the collaboration that actually supports the Lancet Countdown. You'll notice there that it's a very extensive international collaboration. You'll see there that there are Australian organisations and Australian researchers participating in that. This is an example of a set of the indicators. I said there's 43 indicators that it reports on. This is an example of a set of indicators, and it illustrates the kind of information that you could expect to find in those reports at a global level. And so I've just simply pulled up here the indicator around heat. And the most immediate and direct impact of a change in global climate on human health is the steady increase in the frequency, intensity of extreme heat. This is a graph from one of those illustrating those indicators, and it shows the way that that heat over time has changed over time for populations aged over 65 years of age. It's the young and the old and those on certain sorts of medications, people who are unable to thermoregulate, who are most at risk. And so here in this slide, you can simply see how people aged over 65 have been increasingly exposed to heat waves. And also, as you know, the pathophysiology of heat exposure is actually pretty well described. And in addition to including heat stress and heat stroke, acute kidney injury, the exacerbation of heart failure, and the increased risk of interpersonal and collective violence, there is also great risk to the very young, with greater risk of fever, respiratory disease, and kidney disease amongst the very young. So heat is a great killer, and it's a great threat. Since 2018, there's been a companion report prepared by a group of researchers in Australia, and I've illustrated the last set of these reports here on this slide. So the front page, here you have the front page of the Lancet Countdown. In the middle there, you have the 22 report of the MJA Lancet Countdown. And also in conjunction with that, there is a policy brief that's actually highlights some particular bits from the MJA Lancet Countdown. So there's actually, these are produced as a set every late October, November. So there's a building body of evidence describing the health impacts, not only globally, but also for Australian populations. There was very little written about the impacts of climate change on health systems, though, in Australia. And this was a stimulus for the research report commissioned by the RACP. This was overseen by a multi-college advisory committee that I had the great pleasure to chair. This found that the Australian healthcare systems are largely unprepared for the risks that climate change present to their capacity to deliver high quality care. Essentially, Australian healthcare systems are not climate resilient. And I can commend this report to you. It includes very powerful studies illustrating this. And it's very, it's for any of you involved in teaching, it's actually a very good report to use. The health system, though, is part of the problem. In 2018, and following the example of the NHS, Malik and colleagues published the carbon footprint of the Australian healthcare system for the first time and identified that this was 7% of carbon emissions. So this helped us to understand where we stood with carbon emissions, and it allowed us to start planning future measures. This pie graph to the right here breaks down those carbon emissions into its parts. And I flagged that hospitals have a fairly large carbon footprint of about half the total. But I also draw your attention to pharmaceuticals, which is about 19%. So the pharmaceuticals being that large green part of the pie chart. The picture to the left of that, as I look at the screen anyway, which is an international publication, demonstrates that also the carbon footprint of healthcare systems internationally has also been measured, and that's about 4% internationally. Malik and colleagues in New South Wales have also measured it specifically for the New South Wales healthcare systems. And I'll just give you a minute or two to look at this because it's not quite so easy to read as the pie chart. Once again, hospitals come in at the largest, but there are pharmaceutical products as the second largest contributor. If you read across, you can see general practice there as well. So I'll just give you a little period of time to actually read all those things which are sitting on their side. So I'll just move on. So what does the Australian public think about all of this? And there has been an increasing understanding of the Australians public of the impact of climate change. And this is because the Australia Institute has, for the last 5 years, done a national survey called the Climate of the Nation report. And these next 4 diagrams that I'm going to show you are actually drawn from the 2022 report. And so the top line there shows the understanding amongst the Australian population that climate change is occurring. And you'll see that 80% of the population believe that climate change is happening. You'll see from this one, looking at the red component here, that there is an increasing number of people who are very concerned. So the total of people who are very concerned or fairly concerned is sitting there at about 75% of the Australian population. Now, this one takes a little bit of looking at. I hope it's clear, but this actually picks apart some specific concerns. And so you can see here that people understand that climate change is causing more droughts and flooding, that affects food supply. They understand that it causes bushfires. They understand that it's actually affecting biodiversity. They understand that it's connected to more extreme weather events like floods and cyclones, that the Great Barrier Reef that we're losing it essentially, that it causes more heat waves and extremely hot days. And if you continue down, the second last one is that they understand that there are impacts on their health, and that that there is illness related to this through water scarcity, heat, and mosquito-borne viruses. And that's at a reasonably high level, once again, around 75% of the population. Now, this graph here, once again, reasonably complex, but it takes the information from those 5 reports of the last 5 years. And what you can see, I think without a doubt, it's a result of the recent natural disasters that we've had in the last 5 years, is that you can see that that understanding has rapidly increased over the last 5 years. So if you just look at the bottom one, more droughts and flooding affecting crop production and food supply, it's risen from 32% 5 years ago to 50%, and that more heat waves similarly from 39% of the population through to 52%. So we have a really steady awakening of the understanding by the Australian population. So when you talk to people in your practice, then you've got a much more greater chance that your patients are increasingly informed and aware of the risks they face. So just to summarize where we got to at this point, is that basically patients are presenting to health services with the acute and chronic effects of climate change, and that this trend will escalate, that the delivery of health services are increasingly disrupted by extreme weather events, and that with large carbon and environmental footprints, health systems are part of the problem, and that the Australian population is developing a good understanding that climate change is affecting their health. So the NHS has demonstrated that health systems can also be part of the solution, and that reducing carbon emissions of healthcare can be done. And they've been working on this since 2009. And in the first 10 years, they achieved nearly a 20% reduction in their carbon footprint, whilst experiencing nearly a 30% increase in clinical activity. And whilst doing so, they made savings of around £1 billion. In October 2020, the NHS became the world's first health service to commit to reaching net carbon zero. And one of the first things that they did on their journey was to measure their carbon footprint and then to monitor it regularly so that they knew whether they were on the right track and that the interventions that they were introducing were having an effect. And the whole pattern of healthcare systems measuring their carbon footprint as a starting point really comes from what the NHS did back in 2008. So we need both climate resilient and environmentally sustainable healthcare systems. And without a doubt, healthcare systems have started to change. And I just simply illustrate this with a number of documents, including your own, from your own PHN. mean, for example, Hunter New England has set ambitious goals to be carbon and waste neutral by 2030. But I'll just give you a set of some of the other encouraging developments that have happened recently. WA Health has established a Sustainable Development Unit in their health department. New South Wales Health has established a climate risk and net zero program. They have established a climate risk and net zero unit to coordinate and scale all the action across New South Wales Health. Victoria has created a climate change legislation, but it's all patchy at the moment. And what's needed for us to be dealing with this in a comprehensive way is we need system-wide coordinated action at pace and scale. So prior to the last election, the Royal Colleges used the evidence from the report to advocate together for a national strategy on climate change, a national climate change and health sustainability unit to help drive that change along, and to get the Commonwealth to commit to delivering a net zero healthcare by 2040. And we weren't the only ones that were advocating for that, but one of the really important things was that all the Royal Colleges came together and took that consistent message to the Commonwealth and took it to our advocacy positions. Following the federal election, we continue to use that information to go to the Commonwealth, repeating their asks. And in very welcome developments, the new Commonwealth government has passed a Climate Act. It passed a Climate Act last year, so we've got the Climate Act 2022. They've now established a National Health and Sustainability Climate Unit. And they are funding a national strategy on climate change and health. A Chief Health Officer Advisory Group has been established to lead the development of this strategy, and there are consultations for this, which have now commenced. I understand that a consultation document will be released possibly this week, so it should be possible for you to see that. And if I get a copy, I'll make certain I'll send it through to Brendan. One of the other things you need to be able to transition health services is you need a skilled workforce. And currently the health workforce as a whole lacks the necessary skills. And the graduates of health professions education entering the workforce are generally poorly prepared to contribute. So in further welcome developments, the pre-vocational standards for medical trainees in hospitals, which were released this year and which will come into action in 2024, now include reference to climate change. Indeed, it refers people to the need to practice in a way that, and I'll just simply read from the new standards, that the responsibilities of the doctor also include supporting the health and well-being of individuals, communities and populations now and for future generations, teaching and promoting the environmental and financial sustainability of the healthcare system. There's also now a requirement for sustainability and environmental costs to be considered in the rational use of investigations and prescribing alongside of financial cost considerations. So that's a real step up in the expectations in pre-vocational standards. And for medical schools, the accreditation standards for medical schools have been in review for the last few years, and we expect that they will be released in October this year. And we're pretty confident that these are also going to refer to the health effects of climate change as well. So they are big steps forward. Just in a small note, this is a contribution we're trying to make at the University of Notre Dame, which is we've created this graduate certificate in public and environmentally sustainable health. And those 4 courses help people to prepare to be able to be more aware of environmental sustainability in their practice. And one of the courses actually introduces people to how you can use quality improvement frameworks for that. So what can GPs do? And there's a whole range of things that you can do. Every clinical decision, every decision you make has a carbon and environmental impact. So here is just a few suggestions. The first thing is raising awareness about the health impacts of climate change and environmental degradation. You don't need to be experts about climate change. That's the first thing you need to reassure yourself about. You just need to understand how it's affecting you and how it's affecting your patients. You also can be prepared. Heat is the great silent killer in Australia. And there's an increasing range of people illustrated here, the elderly, those in various occupational groups and sports people who are at risks. You know, you can have ways of systematically identifying your patients at risk. Do these individuals have plans to self-manage on those days? Are you looking after yourselves on those days, which are very, very hot? We can learn from the NHS. The NHS is 10, 11, 12 years ahead of us all in their actions. They've done a lot of work in the pharmaceutical space. For example, they've launched new primary care incentive scheme to support the shift away from high carbon inhalers, which will pretty much limit those and not only limit, but eliminate those emissions in the next couple of years. The Choosing Wisely program, which you're all very, very familiar with, has demonstrated how by simply not doing things that don't make a difference, you can actually also make a difference to the patients, but you can also help the environment. You know, please consider the tests you order. Are they all necessary? And we know that COVID demonstrated for a whole range of things, like including this presentation tonight, that there's ways that we can actually engage with people through the digital environment, which means that there's not only cost savings, but there's also carbon savings, rather than having people always undertaking things in a face-to-face environment. Quality improvement, the NHS uses quality improvement for considering the environment very, very successfully. And when you're purchasing things at the practice level, just think about where you get your power from. Are you purchasing renewables? As far as advocacy goes, yours is a very trusted voice. And remember that when it comes to advocacy, you do not need to go it alone. You can join with other voices. The RACP has been very effective in its advocacy, and there are other PHNs who are active in this space as well. So just in conclusion then, the recent IPCC reports remind us that there's a closing window of time to take action. We possibly have until the end of this decade. I'd just like to emphasize that every fraction of degree of warming that we prevent or slow makes a difference, and that Australia is now, I believe, at a tipping point that large systems, large health systems like the NHS have rapidly transitioned. We can do this too. So thank you very much indeed.
And thank you very, very much for your presentation. And it was your presentation about a year or so ago, 18 months ago, I think it was, that actually motivated us to take our path on looking at the relationship between climate change and population health. And I'm going to give a bit of a summary of—
Brendan, sorry to interrupt you. We can't hear you very well. Is your head the mouthpiece? Yeah.
Try that. Sorry, we've had some ID issues tonight. Let's hope they go away. Thanks to Lynne for her presentation. What I might do now is to, if Christina can bring up my presentation. Thank you for that. Again, Lynne provided the motivation for us to try and identify what we can do as a primary healthcare network. And so what we have done is taken up that mantle and developed a climate change and population health statement with an implementation plan, and that's what I'll go through tonight. Next slide, please. So under our climate change and population health statement, we've committed to 5 key actions. These are to raise awareness about the health impacts of climate change and environmental degradation, to try to collaborate to identify practical strategies to respond to the health impacts of climate change and environmental degradation, to strengthen primary care's capacity to implement environmentally sustainable practice, and I'll be talking about one of those initiatives in a minute. Also to try to adopt environmentally sustainable practices to reduce CESPHN's carbon footprint. And next slide. Okay. So I've just got to adjust my slides here a little bit, my screen. Okay. It's not quite coming up. That's fine. So our work so far, one is what we've done is we have, again, developed up the climate change and population health statement. We have within our PHN established a climate change working group. We've looked to try and reduce the use of power and utilities, try to improve recycling, and we're also trying to promote sustainable behaviours. In terms of looking outwards, what we've done is we have developed up a green practice checklist. I have to say to you, it's probably the first of its kind, I would think, in terms of initiatives that are happening locally for general practices. We've added a clause to our contracts, again, to encourage sustainability. The PHN does a lot of commissioning, so we've added a clause to those contracts. We've also undertaken a range of CPD events, and again, forgive the technology tonight, but we intend to do a lot more. And we've also been doing as much as we can in terms of around advocacy and awareness raising. Kylie and I collaborated and wrote an article in the Health Advocate around climate change and population health. Next slide. So just try and adjust my screen a bit as well. There we go. That's better. It's not quite coming up right, but so we've developed up a green practice checklist. This is a self-audit tool for general practices, but also allied health services to undertake an environmental assessment of their workplace. It will help practices identify ways that they can be more sustainable. And it's also designed to look at trying to design to benefit your patients and your practice to ensure that your business aligns with best practice green principles. Again, our focus is on energy consumption, waste management, promoting sustainability, and again, the issues around prescribing and testing. Next slide. So what we intend to do now is to do some further work in terms of disaster management planning. As Lynne has identified, this issue is, we all remember, I think, the issue around smoke in our communities that lasted for about 6 months. We anticipate that there'll be more extreme weather events. So we need to get involved in doing that initial planning now to prepare our communities for those extreme weather events. We're also collaborating with other PHNs and community organisations, and I have to say from August, I'll be chairing the New South Wales disaster management group for the PHNs. We're also embedding climate change into our practice support visits. We've got about 585 general practices in our region, and somewhere between 10, 12,000 allied health. Again, as much as we can, we'll be embedding climate change into those visits and to provide resources. I mentioned the issue around resources. We're really committed to try to get the messages out, but to do things in a way that's really, really practical, to really about providing education. Next slide, please. We'd also like to, Lynne mentioned the issue around COVID. We know that there was a lot of waste in terms of COVID with some of the health products. So what we'd like to do is try to look at how we can develop up a green practice checklist for residential aged care facilities. We also want to put some sustainability provisions in our tender documents for when we go out and commission services. And of course, what we want to do is use our website, which is a really main communications tool, and really try and develop up an information hub on our website to act as a bit of the go-to resource, if you like, for primary care providers in our region. Next slide. So that's it from me in terms of what we're doing. I wanted to highlight what we're doing because we often get asked, and it's important that Lynne has set that broad picture. What are we doing locally? Well, that's what we're doing locally. Now, what I would like to do now is introduce to you the one and only Dr. Margot Woods. Margot has worked in general practice for, well, can I say this, for more than 25 years in Balmain and Rozelle since 1988. Margot was the founding doctor at Rozelle Total Health. She studied medicine at the University of Newcastle and graduated in '84 with a first-class honours. After working in Sydney in hospitals and general practice, she moved to London to get further experience in obstetrics and gynecology and life, and then returned to Australia to become a GP. So, Margot, I think you're going to give us a bit of a presentation on impactful strategies to implement in practice, something really concrete. Over to you.
Thank you. Thank you so much, Brendan. Really appreciate the opportunity. I'm just trying to get my slides up, sorry. And hopefully you can see those now. Okay. Yeah, so thank you for inviting me. I really was just a bit more of a sort of personal perspective and what, what we can do with all of the knowledge that we're gradually gaining. First, of course, before we start, I'd like to acknowledge the traditional owners and custodians of the lands that we are all on. In my case, that is the Gadigal people. Also, it is Reconciliation Week, and it made me think about how much our Aboriginal traditional owners actually have to teach us. This is a quote from a Palaku woman, Amberlyn Kewamolina. I don't know if I've said that quite right, but I guess it really resonated to me. The country is loved, needed and cared for, and the country loves and cares for its people in return. So I think that we have a lot to learn from our Indigenous heritage. I guess where do we come from? I wanted to mention just in 2019 that the Royal Australian College of General Practitioners recognised climate change, and as Lynne said, have been participating with the other colleges as well. But for me, I guess it was really, when I heard it was 7% of the national footprint, carbon footprint, I guess I sometimes think, well, what can I do? And I guess really for me, I'm not here to lecture you. I'm certainly no expert, and I'm certainly not here to preach the converted, which probably you all are if you're actually here at a climate event. But personally, I want to just reflect on things such as my emotions that I've had, which have really gone from everything from fear to anger to feeling overwhelmed and certainly guilty, particularly when I've got children and now a grandbaby. What have I done? I sometimes think to myself, watching the news is a health hazard, and it's all ruined and it's all too late. And I think we need to accept that our patients often have exactly those emotions, don't they? And that mental health is actually a really big part of what's going on, and we need to support our patients. But for me, it's a matter of picking myself up and thinking, well, I need to become more aware, more empowered, and really look at those two words, mitigate and adapt, and see how can I do that? And I think tonight, just a couple of examples I thought I wanted to share with you. And I guess really, and bringing our patients along who are distressed as well. First thing is, I'm sure you've all either seen in your inbox in the last week or so, or your letterbox, the Australian Journal of General Practice in the May edition, which is actually about climate change. So there's some really good things in there to have a look at and learn. So I think in my head, it's really like the non-clinical things and then the clinical things. And we've gone through our green checklist, as Brendan has sent to the practice. And I'm in a really privileged place because I actually was able to put in solar panels. I know that not everyone can. I'm also really privileged because I get to walk to work, something that I really enjoy, but I know not everyone else can. But I guess there are some things that I'm still working on. One of them is really around workflow. And I think for me, the biggest one there is trying to get better in embracing e-everything. So e-faxes, e-scripts, email, e-referral. My main one that I really love is HealthLink. I send just about all of my referrals now on HealthLink if I've got something that they've got an address. I love HealthLink. First of all, no printing. Secondly, it gets where it needs to go and they don't get lost. So I'm struggling with some things still. E-prescribing I embraced, but a lot of patients don't quite like e-prescribing. They don't seem to be able to manage their scripts on their email or their SMS, but I'm getting better. And just to flag that great support from my practice. So George Marshall, thank you very much for being my fabulous IT support. And I promise I will do better. And it may be one day I won't even need a printer in my room. Lynne, you mentioned telehealth. Absolutely. COVID's brought us a lot of things. And I think telehealth is one that we need to work well with. It doesn't work for everybody and for every illness, but it certainly does work well for things such as giving out results or a repeat prescription or simple things. Why do patients need to travel to me for things like that? So I walk to work. A lot of my patients might actually drive to work. So what can I do to actually decrease their transport? So I think there's a couple of the things in the sort of non-clinical world. I guess for me, the clinical world is probably where I live more. And for me, the main thing, I've been long a passionate prescriber of lifestyle medicine and preventive health. I really do think we can do an enormous amount with things that we can actually get people out into nature. You've heard about green bathing. Now there's blue bathing, so get them out in the trees and the water. Get them moving, get them socializing. Incredibly powerful medicine and very low emissions for mostly. I think diet is an enormous one too. So looking at how we promote planet-based diets, not plant-based. You're allowed to eat some meat, but maybe meat that's has a lower carbon footprint. I think the main ones there is eat local. I don't need to have those cherries imported from California. I don't need to have seasonal fruit in the wrong season. And the big one is don't waste food. Buy what you need and consume it. Nothing better than my leftovers for lunch in the lunchbox in the fridge each day. Diet, poor diet, I don't need to tell you, was a major driver of the non-communicable disease epidemic. And food production accounts for about 30% of the greenhouse emissions, man-made greenhouse emissions, and 70% of freshwater use, which is huge, isn't it? So we can do a lot by getting people moving, by getting people eating well. And hopefully that's part of our not prescribing, which we'll come to in a minute. So prescribing, but non-pharmaceutical things, is hugely powerful. Again, Lynne said, think about everything we do. It's all got a carbon footprint. I guess for me, the one thing that's exciting to me at the moment is cervical screening. When I think about, I used to get out a disposable speculum in a plastic bag. Don't know why it had to be in a plastic bag. I'd open an individual sachet of lubricant. I would then use my disposable plastic spatula to do my cervical screening. Now, not only do I not have to have women tolerating a speculum insertion, they can do their own, or I can help them with a cervical screening swab. Doesn't come in a plastic bag. It is plastic, but it's one swab. So it's hugely, huge improvement. And when I think about using the estrogen before I'm doing my cervical screening, I've got some choices. I don't know if you've ever looked at the packets. Vagifem comes with a little tablet, each with its individual plastic vaginal inserter. Very wasteful. If I look at Avestin, I can use the same applicator, simply rinsed out, for the whole packet. So I think it's everything, every step of the way, thinking about how we actually can consume less and create less waste, as just a couple of examples. And I think, again, I very much agree with Lynne. We really need to look at our vulnerable populations, who are going to get impacted the most. And they are those, as I said, the young and the old. And I might come back to that one in a minute, because there are a couple of resources I thought I'd share with you. So we talked about the poor diet. This is the planet-based diet. So it comes up with, you can eat some meat, but try and eat something that have a lower environmental footprint. Eat local, eat in season, and reduce the food waste. Okay, I thought this was a good question. What was the biggest contributor to my carbon footprint today after just running back from the surgery? Well, you all know now, don't you? Pharmaceuticals. And I love the question we've got in the chat, which is how does that happen? So we're going to learn from Lynne and Brendan about that soon. But definitely it was pharmaceutical prescribing. So they think in the UK, in general practice, it's about 50% of the carbon footprint comes from pharmaceuticals. So it's one we can certainly look at. But again, what can I do? Well, you know, I'm a doctor. It kind of comes with the territory, doesn't it? I prescribe. But there are things we can do. And I guess the first thing that comes to mind for me was deprescribing. I must admit, I opened my patient files and I've got a shocking number of people who have polypharmacy. To my credit, there are very old people, many elderly people with complex things, but polypharmacy or more than 5 medications is not that uncommon in my patients. We know that from 20 to 21, 54% of PBS medications were prescribed to people over 65. That's probably my population. We also know that every additional medication that we add to that age group increases the medical risk of harm by up to 11%. So it makes sense, doesn't it? Deprescribing makes an awful lot of sense. And also I can just also decrease my carbon footprint. Just a little tip, Health Pathways has a really good deprescribing pathway if you're not quite sure where to start, but it's really good. Okay, first thing, I'm deprescribing. Second thing, I'm thinking before I prescribe. Do I really need to prescribe it? And we'll talk, I'm sure you all know about asthma and COPD, but I was really shocked to hear that there are several million metered dose inhalers used annually in Australia. Several million. And that, as you know, the only over-the-counter reliever is if salbutamol is in a metered dose inhaler. We can't actually get that in a powdered inhaler when people go to the chemist and ask for one. I remember when we were told the CFCs, which were ruining their ozone layer, they're all gone now, so you didn't need to worry about it. Well, I think we're sold a pup because the hydrofluorocarbons that are in them now are actually incredibly potent greenhouse gases. Apparently their effect is thousands of times greater than the equivalent of carbon dioxide. So we do have choices. The other one is to think again before I prescribe, do I have an accurate diagnosis? In some studies around in Canada, about 1/3 of the people diagnosed with asthma and about half of the people diagnosed with COPD did not actually have the diagnosis, even after they stopped the medications. We know that good control means that people are going to the chemist and buying far fewer SABAs. They're not using their metered dose inhalers anywhere near as much if I've got them under good control. And I probably should have put lifestyle first. As I said, it's my passion. Get people moving. How many of my patients with COPD would have done a lot better if I'd managed to get them to respiratory rehab? Work's a treat, obviously. Smoking, weight loss, fitness, a lot of things that we can do to actually improve asthma and COPD. And that's not even mentioning air pollution and the worsening that might occur with global warming. We also have drug choice. Okay, so there's an article in that HAGP about respiratory inhalers in the environment that you can look up. But just really quickly, I certainly use more of my dry inhalers, dry powder inhalers, use less of my metered dose inhalers. And I know you're going to say it doesn't comply with PBS. Well, it should, shouldn't it? So we need a little bit more advocacy to say, why can we not get all of these in metered, get rid of our metered dose inhalers and get everything in dry powdered inhalers? It should be possible, shouldn't it? The last one, I was just really quick because I appreciate we're probably running out of time, is just thinking about a pathology and radiology. So this is an example. If I'd ordered this set of bloods, not that I order arterial blood gases very often, what would be the equivalent in the carbon dioxide emission? It's about 0.8 kilometres driven in a car. 0.8 kilometres. So I probably order equivalent to that many times a day. So thinking again, I agree with you, Lynne, the medicine wise is a great way of looking at it. I think I'm going to maybe misquote now, but the metered dose inhalers with the salbutamol, I think each one is equivalent to driving about a kilometre. But I might have to check that fact, sorry. Anyway, so thinking about how much of a footprint, the pathology testing and diagnostic testing, it's about 9% of our carbon footprint in healthcare. So it is significant. And then just really quickly remembering our vulnerable patients, as we said, those ones that are being directly impacted by the effects such as heat waves, droughts and extreme weather, usually the young and usually the old, but also things that we've mentioned, the air quality and water and food supply and the quality of that food. So those who are frail, those who are young, and also those with less resources are definitely going to be impacted more. There's, again, going back to health pathways, there is a great health pathway on heat-related illness. And one of my quality improvements is probably actually picking out all the patients that are actually going to suffer and make sure that I've actually written them a heat wave, what they should do, how they should hydrate, how they should keep cool, which medications they should cease. There's another great one, which is Brendan has mentioned, general practice management during a disaster. Unfortunately, I think we're going to be facing more than those. And again, I'll just mention again the impact of mental health, which we won't go into. So that's my very brief run through. And I really wanted to go back to that. Countries loved, needed and cared for, and country loves, needs and cares for people in return. So 90% of Australians see a GP every year. We have so much power and opportunity to educate and advocate. I'd like to thank the PHN for embracing this. It's been fantastic. And just one little wish, be kind to the planet, be kind to yourself. Thank you.
Well, thanks, Margot. That was a fantastic, really practical presentation. It's really good to hear what can be done by one of our local GPs. We've now got some time for some questions, and I think I might actually put the first one to you, Margot, which is, do you ever talk to your patients around climate change and the impact on their population, on their health?
Yes, I do, because I think that it is so relevant. As Lynne was explaining, we've got an increasing number of people who actually understand what's going on. And I think we are a very trusted people. We talk about, that's how I fit in all the lifestyle things, that how we can actually help people make some changes themselves rather than feeling completely overwhelmed by this.
And how do your patients react when you start talking to them around these kinds of things? Does it put them off? Do they go, yes? Are they genuinely interested?
Mostly they're polite, Brendan. Some of them may not engage, but I think it's really, we're talking about lots of things about preventive health, aren't we? And lots of different things that people aren't necessarily wanting to hear. And I think it's the ongoing relationships that we have that privilege of knowing people for a long time. And so you don't actually have to preach. You can actually just do these messages slowly and make them relevant to the patient.
Yeah, that's great. Look, thank you for that. And Lynne, we've had a couple of questions in the chat, which is around, sort of Margot addressed it, but it's worthwhile talking about it a bit more, I think, which is around the role of pharmaceuticals and around the issue around packaging. Do you want to respond to that issue?
Thanks very much indeed, Brendan. I wouldn't say I know all the ins and outs of the carbon footprint of pharmaceuticals, but my understanding is that most of the energy weight comes from the production process, and that they largely are using coal power energy when they are being produced. They're very energy dense production processes producing pharmaceuticals.
One of the questions that we get a lot is a PHN, and we see ourselves as being leaders in this area. But we get a question a lot, which is, yeah, but what can primary care really do? How, can we actually do anything? And really, is it going to make much difference? That's probably the most typical question we get. Can you help us out by giving us an answer?
But I think that, thanks, Brendan. I think that sort of in my presentation, and I think that Margot then picked up, that there's an awful lot that we all, in all aspects of clinical practice, there's a lot that we can all do. And I think that Margot provided a very nice sort of way to think about that from, and as you also illustrated, there is the things that we need to do to adapt, and there's the things that we need to do to mitigate. So by adapting, it's about being ready, it's about creating climate resilient systems, and primary care has an immense role to play there. As Margot says, you are this is where people are most receiving their care. Certainly hospitals need to adapt, but they're actually only really looking after a small fraction of the community at any particular point in time. So making certain that you yourselves are climate resilient, that you're looking after yourselves, that your ways of being and the ways that you practice are adapting to the threats that are coming through is really, really important. And then helping your patients also to adapt so that they are ready to be and knowledgeable to take control of their own health, particularly in examples like heat. How do I look after myself? How do I don't expose myself? How should I not expose myself to unnecessary risk? And then there's all the things that also Margot described about mitigation, about dropping the carbon and environmental footprint of practice in general practice, about different types of prescribing, about less prescribing, making certain that what we do is really what needs to be done, rather than unnecessary testing, unnecessary interventions. So without a doubt, primary healthcare has an immense role to play.
Look, thanks for that. And tonight we've sort of addressed the issue around GPs, but I would think that some of our dear colleagues in allied health would also be interested, that a lot of the arguments would be exactly the same. Is that correct?
Yes, I think, no, without a doubt, every health professional is going to have to change their practice. I mean, that's essentially where we, for us to hit what is the goal, which is a 2040, 2050 net zero healthcare system in Australia, all modes of practice are going to need to change. So as you saw from those carbon footprints, though, that allied health tends to have a much smaller carbon footprint,
yep.
But nevertheless, all the things that we've talked about here, things like, for example, do people have to go to a location to actually have an allied health intervention? Or are there ways that we can actually go to people in their homes? Or can we set people up with programs that can then be monitored at a distance? So without a doubt, allied health also has will be evolving and want to evolve. So people like physiotherapists, people like pharmacists, everyone wants and needs to change.
Thanks for that answer. It seems to me that health providers are leaders. They're leaders in their practice, they're leaders in their community. People look up to healthcare providers. And I'm also wondering too around what are the sorts of skills that we as health providers need to take on to terms of doing that advocacy type work, about influencing beyond simply our patients, but influencing other members of our community, local councils, community groups, etc. like that. Is there a role in doing that?
Well, just a quick one. Without a doubt, I think that we also touched on that the health voice, doctors, nurses, other health professionals are a very trusted voice in our community. And it's important that when we do advocacy, it's one of the things that I've learned by chairing the Climate Change and Health multi-college group, is that people feel very, very strongly that when you advocate from a medical position, so I'm just talking about us here as doctors, it's really important that we advocate from an evidence base. And so that when we talk to people, they know that they can come to us for evidence base. There's a strong evidence base for what we're saying.
Look, thanks. Yeah, Margot, you have any comments on that as well?
Oh, no, totally agree. And it's, I guess the other thing is, for example, I live in my own community. So people see that I walk. People see that I use active transport. I think we can actually demonstrate to people in the community. And I think we do, it is a very important role. And I absolutely agree, Lynn, that it's got to be evidence-based and it's no point hysteria. And we need to be actually basing all of these comments on the evidence and also trying to be positive and giving people actions that they can do.
Yeah, look, that's great. And look, go ahead.
So the other thing I would just simply say is that you don't have to do advocacy alone. And if you don't feel comfortable doing advocacy, all you have to do is get in behind your college or what your PHN's doing. So you don't actually have to be out front yourself. You can just simply support what other people are doing, add your voice to others.
Yeah, look, thanks for that. Look, I just want to put in a bit of a plug for our Green Practice checklist before we end tonight, all right? Look, our Green Practice checklist, we've sent that out to practices, Allied Health as well. We're really keen to get as many people as possible, as many practices as possible to complete that. There's no losers in this. Everyone gets a medal, gold, silver, or bronze. And the aim around this is to say to people, look, hey, just stop, fill out the checklist, see how you go on that. It's about doing a bit of self-reflection. That's all it is, right? And that self-reflection is, we think, is critical for you to understand how your practice works, how it can reduce its environmental footprint. Someone just made a comment in the chat, which I think is useful, which is that that it's really important also to build coalitions with the other businesses that support these kinds of ideals, which is why, in part, the PHN is putting clauses into our commissioning contracts. But again, I just want to highlight that, and I welcome any comments from Margot or Lynne on this, but it's about building those local business coalitions to drive change. I
totally agree, Brendan, but I'd like some help. I would like some help to know which is the best energy to use, which is the best, which I don't know how. It's overwhelming, the number of decisions that we have to make, particularly running a practice. It's so complicated. And if you come back to things like pharmaceuticals, I'm desperate to go and have a look at the NHS and to find out, is there a difference in the footprint of, if I'm choosing an antihypertensive, does it matter which one I'm choosing? So I really love to sort of get some support, drilling right down into how do I make those choices? And I'm really keen to find out what more CPD events that you might have that actually will help me learn, because I've got a lot more learning to do. So I go, yes, I should use less pharmaceuticals. But when I've got to use them, and of course I said it's part of my job description, I need some help to know which ones. How do I make good choices? And I feel very ill-informed, whether it's about medical things or the management things or my energy resources. So I'd love to get some support as a group to find out, so we can also work as a coalition of people who actually are voicing these things as things that we're interested in. Yeah, look, thanks for that. And the role of community pharmacists is also, I think, pretty essential as well. They are trusted in the community, and I think they can also have a really strong impact on, influencing how people, interact with their medications and the kind of packaging and those sort of products. So.
That's just an example around pharmaceuticals, but just about sort of local partnerships, I also just simply flagged local councils. Local councils are doing some fantastic work. Randwick Council has got collections going for picking up old radiographs, x-rays. Blue Mountain City Council, if anyone knows about Blue Mountain City Council, has a planetary health initiative. So there's some fantastic things happening in local councils, and PHNs are incredibly well placed to be working with local councils. Just picking up on the pharmaceuticals, one of the things that's been recently brought to my attention has been the wastage of chemotherapy treatments when people come to hospital for a chemotherapy treatment when they haven't had the necessary, they're not feeling well, or if they're and so unable to receive. or they haven't had the necessary blood tests in order to make certain that they're able to take a treatment. This seems to be particularly a problem in some of the rural areas, but it just simply flags that there's all sorts of efficiencies which aren't necessarily about changing practice. It's just about making so that we don't waste stuff, because when it's wasted, it also has an environmental footprint.
We're coming up to time now, but thanks, Lynne, for that answer. Can I also thank Margot for her wonderful presentation tonight, and also Lynne, who basically helped motivate us on this path 18 months ago. We're incredibly grateful for that. We're not letting go of this issue. We are going to continue as a PHN, taking up responsibility for this as well. We've got a part to play in promoting this to general practice, but also allied health. We will continue to do this. So I'm really grateful for Lynne and Margot for your support.